Published in the American Journal of Obstetrics and Gynecology is a review, Modern Labor Epidural Analgesia, Implications for Labor Outcomes and Maternal-Fetal Health. Epidural analgesia is an important means of pain relief during labor, particularly in the United States, where 4 to 5 nulliparous women now receive labor epidural analgesia. Modern approaches to epidural placement typically involve one of 3 techniques. A traditional epidural, shown on the left, uses loss of resistance technique to localize the epidural space, and a catheter is threaded to deliver analgesic agents throughout the labor course. Alternatively, a spinal needle can be advanced through the epidural needle into the subarachnoid space prior to threading the catheter in the epidural space. If the spinal needle is used to deliver an analgesic agent into the intrathecal space, this is termed combined spinal epidural, or CSE, and is shown on the right. If cerebrospinal fluid return is simply visualized and no medication is administered, this is termed dural puncture epidural, or DPE. Once the epidural catheter has been placed, medication is usually delivered by means of a programmable pump. A background amount of medication can either be delivered via continuous epidural infusion, CEI, or as programmed intermittent epidural boluses, termed PIEB. Patients may be given the option of patient-controlled epidural analgesia, PCEA, which allows them to self-administer doses above and beyond the basal CEI or PIEB should they have inadequate analgesia or breakthrough pain. Displayed here is a dosing scheme for programmed intermittent epidural bolus every 40 minutes with PCEA included, showing patient-requested PCEA dose in red. In studying the effects of epidural analgesia on the labor course, several significant limitations are important to note. First, defining labor duration for research purposes is subject to variability. Second, because the population of women who request or require epidural is different from those who do not, there is a significant risk for selection or allocation bias in observational or retrospective studies. Finally, epidural analgesia itself may be linked to the mode of delivery. For example, a forceps or vacuum delivery may not be offered to patients without epidural, or an epidural may be placed in anticipation of these techniques. Uncorrected for, this may give the appearance that epidural is associated with these delivery types. In assessing the effect of epidural on the first stage of labor, the data are conflicting. However, one of the highest impact investigations is the Cochrane review of randomized controlled trials conducted by Samua et al. In 2018 comparing labor epidural to alternatives. They demonstrated that patients receiving labor epidural analgesia had a first stage 32 minutes longer when compared to those receiving opioids. In the subset of studies that compared labor epidural to placebo or no analgesia, there was no difference in first stage length. While this may be a demonstrable effect, it should be interpreted in context. A half-hour delay may or may not be a clinically significant amount compared with the whole labor duration, and for any individual patient, the benefits of pain relief may outweigh the risks of a 30-minute delay. For the second stage, large retrospective studies have shown significant prolongations. Chang et al. Published a retrospective cohort study of 42,000 patients in 2014 and showed a 73-minute second-stage delay in the epidural group. However, in Samua's Cochrane review of prospective, randomized studies, they saw a more modest difference, a delay of 15 minutes when epidural was compared to opioids, and no difference when it was compared to placebo or no analgesia. Again, while this effect does emerge in careful study, it's unclear whether a 15-minute delay would be clinically significant. Importantly, Samua et al. Demonstrated no adverse short-term fetal effects, including depressed APGAR scores or neonatal ICU admission. Theoretically, the local anesthetic component of labor epidural solutions can lead to motor weakness, which may inhibit maternal ability to push and could predispose parturients to operative delivery, either assisted vaginal delivery or cesarean delivery. This was addressed in a meta-analysis by Halpern et al. In 1998 of 10 studies comparing labor epidural analgesia to parenteral opioids. They failed to show a higher risk of cesarean delivery in the labor epidural group, with an odds ratio of 1.5 and a confidence interval crossing 1. Multiple subsequent high-quality studies have shown no increased risk of cesarean delivery with epidural, including the Cochrane review conducted by Samua et al. Halpern's study did suggest an increased risk for assisted vaginal delivery in the epidural group. However, in Samua's Cochrane review, a subgroup analysis of the studies published after 2005 failed to show this increased risk of assisted vaginal delivery, as shown in this forest plot with the blue diamond crossing 1. One hypothesis to account for this observation is the development of newer epidural techniques over time has led to lower risk of assisted vaginal delivery. Some of these developments are discussed next. Advancements in labor epidural analgesic techniques have favored the use of more dilute local anesthetic solutions. A meta-analysis of 13 randomized controlled trials conducted by Sultan et al. In 2013 showed that low-concentration analgesic solutions equivalent to 0.1% bupivacaine or less were less likely to be associated with assisted vaginal delivery, demonstrated in the forest plot showing an odds ratio of 0.7 for the studies with low concentration solutions. In fact, in 2017, a meta-analysis of studies comparing labor epidural analgesia with 0.1% bupivacaine equivalent or less to non-epidural analgesia showed no increased risk of assisted vaginal delivery with analgesic concentrations in this range. It is also important to consider the effects of the maintenance technique on the mode of delivery. In 2019, Xu et al. Published a meta-analysis of 11 randomized controlled trials comparing programmed intermittent epidural bolus with PCEA to continuous epidural infusion with PCEA, and demonstrated a lower risk of assisted vaginal delivery in the programmed intermittent epidural bolus techniques, shown in the bottom right forest plot, odds ratio 0.51. The two different modalities are comparable for the risk of cesarean delivery. This suggests that PIEB is also favored to promote spontaneous vaginal delivery. One significant effect of epidural analgesia on maternal physiology is hypotension, which is a well-understood effect of local anesthetic medications in the neuraxis, mediated through vasodilation. In 2015, Freeman et al. Conducted a multi-center randomized controlled trial to assess labor epidural analgesia versus intravenous remifentanil patient-controlled analgesia. While their primary outcome was related to maternal pain relief, they also assessed hypotension as defined by systolic blood pressure less than 90 millimeters of mercury, and found, unsurprisingly, lower blood pressures in the epidural group, risk ratio for the remifentanil group 0.75. The significance of this is unclear, as there were no major related adverse events reported, and with appropriate monitoring and fluid therapy, any effect is often mitigated. Epidural analgesia has also been associated with maternal fever in multiple randomized controlled trials and observational studies. The etiology is poorly understood, but possibly related to systemic absorption of local anesthetic medications causing a non-infectious inflammatory syndrome. A 2020 meta-analysis conducted by Janssen et al. Included both randomized and observational studies of labor epidural analgesia versus alternative. Among the randomized controlled trial subgroup, they found that the relative risk of fever in the epidural group was 3.54. There was also an increased risk of maternal antibiotic administration in the labor epidural group, but only in the non-randomized studies. There was no increased risk of neonatal sepsis workup. Despite the reproducibility of this effect, the implications of this on maternal-fetal health remain unclear and warrant further study. Finally, with respect to fetal effects of labor epidural, there appear to be no significant differences in short-term fetal outcomes. While some studies have shown increased incidence of fetal bradycardia, particularly with the initiation of epidural, 5-minute APGAR scores appear to be no different for neonates of parturients receiving epidural, and acid-base status may actually be improved in the setting of epidural. Reynolds et al. Conducted a meta-analysis of studies assessing umbilical artery pH and base excess in neonates of parturients with and without labor epidural analgesia. For those who received epidural, base excess was less negative, i.e. closer to physiologic, and among randomized controlled trials, the umbilical artery pH was also higher, i.e. less acidemic. In conclusion, with a growing body of evidence, there is minimal clinically significant effect of modern labor epidural analgesia on the duration of labor or mode of delivery. Specifically, the advances of low-concentration maintenance solutions and programmed intermittent epidural bolus with PCEA techniques have been shown to favor normal spontaneous vaginal delivery. Epidural may cause maternal hypotension through a well-recognized means, but the clinical significance of this is unclear. Epidural-related maternal fever is a reproducible phenomenon, and its implications on maternal fetal health should be studied further, but epidural has few short-term perinatal fetal effects.